Hello, everyone. I do see a bunch of you in the lobby, so I'll give you a couple minutes, or a minute, I should say, to let everybody in, and then we'll get started at the top of the hour. All right, I do still see some people in the lobby, but I'm going to go ahead and get us started, and you can join us as you can. Hello, everyone, and welcome to the Rural Health Executive Educational Series. I'm Cody Smith, Director of Rural Partnerships with NRHA Service Corporation, and I'm happy to be your moderator today. Before we dive in, a few quick things to know. This session is being recorded. You'll receive an email to that recording later today. Please feel free to share that with anyone who would find the information useful. Rewatch whatever works for you. Also, at the end of the session, there is a quick feedback survey. I know we don't like to do surveys, but if you could please help me out and just take a look at it really quick. I take all of your input and make sure that we're making these sessions as relevant and useful for you as possible and your peers. So thank you in advance. Quickly, we'll cover a few housekeeping items. All attendees are muted, not because we don't want to hear from you, but it just helps us run the session a little smoothly, or a little more smooth. Presentation should last 30 to 45 minutes. This does allow for some time at the end for question and answer, but please, if you have a question, don't wait. Go ahead and drop it into that question section on the control panel as it comes to mind. This is your chance to take the experts' time and get some advice, and I know they love to hear from you. So today we are excited to have an exceptional speaker. Clare Kelley works with critical access hospitals and rural health systems on affiliation strategy, physician planning, and long-term sustainability. She advises rural leaders on evaluating partnerships with larger systems, assessing financial risk, strengthening clinic operations, and developing strategic plans that preserve local access to care. Her work helps rural executives make informed decisions about growth, alignment, and service viability, ensuring communities can maintain essential healthcare services in what is an increasingly complex environment. With that, Clare, I'm going to go ahead and hand it over to you.
Thanks so much, Cody. And thank you all for being here today and for registering for this webinar. I'm excited to be speaking with you all around medical staff development plans and provider strategies and how they can really benefit rural hospitals. As Cody mentioned, my name's Clare Kelley. I'm a senior consultant with Stroudwater Associates. I specialize in all things rural strategy, whether that's provider strategy and crafting medical staff development plans or provider needs assessments, or if it's understanding the risk of rural hospitals and being able to articulate the value of rural hospitals to larger regional referral centers. I love all things rural and all things strategy. For those of you that don't know Stroudwater is a leading national healthcare consulting firm. We work in all 50 states in a given year and live and breathe rural healthcare. It's our bread and butter and what we love to do. And our mission is to help continue to make rural hospitals sustainable and be able to serve their patients and their community. So to kick us off, I'm going to start with a polling question. And that polling question is around, let's see if we can get that to pop up. Yep, perfect. So how old is your most recent medical staff development plan? And do you even have a medical staff development plan? And it's absolutely okay if you don't. Usually, a lot of people don't have a medical staff development plan, so that's completely fine. And I'll give folks about 20 more seconds to respond. Awesome. Great. Looks like we're almost about 50% of folks have participated, so thank you so much. Awesome. So about 55% of you do not have a current medical staff development plan. I'm so happy you're here today to talk about this with us. It's going to be a great session then. About 10% of you have one that's less than a year old, 18% 1 to 3 years, another 18% 3 years or more. So why are we bothering to talk about medical staff development plans? Why do they matter to critical access hospitals? Why do they matter to rural hospitals? I don't think it will come as a surprise to many of you that the US is facing a pretty steep physician shortage. And by 2036, it's estimated to be a shortage of about 86,000 physicians. And there's a lot of reasons behind this shortage, but a large one is that 42% of the current physician workforce is ages 55 plus, with 20% of that 42% ages 65 plus. So you've got a lot of your current physician workforce that's nearing or at retirement age and really starting to reduce some time and go to that post-career lifestyle. So with this anticipated kind of retirement that we're seeing pending, that we're anticipating that rural geographic areas are going to be hit harder by the shortage, and we're already seeing the results of that. Recruitment times for specialists for rural areas is averaging between 18 to 24 months. So what can we do to proactively take steps so that you don't have gaps in access to care? So for example, that general surgeon that's going to retire in the next 6 months, and it may take you 2 years to bring on another one, you don't have that 1.5 year gap in access to care. How can we work so that you're shortening that length of time and really mitigating that risk? And that's where a medical staff development plan, and better yet, a provider strategy, comes into play and can be really beneficial for your organization. So a couple goals for this presentation today. The first is I want folks to be able to understand the unique components of both a medical staff development plan and a provider strategy, how to effectively use your medical staff development plan or your provider strategy in your organization, and how to set your organization up for success by using it, understanding how long-term recruitment and how that plays into a provider strategy and can really help both your current staffing needs and your future healthcare demands, how to not only recruit individuals, but work on alignment and certain operational processes that are going on in your organization to make your organization both more attractive to future providers, but also help you retain the providers you currently have, how to engage with those providers around those operational improvements, how to invite them to have a seat at the table and have collaborative discussions. And then finally, we'll also have some case studies from some really great examples of how organizations have been able to use provider strategies effectively. And then really quick, here are the different components we're going over today, the unique components of medical staff development plan and provider strategy. Then we'll talk about really the importance of provider strategy, and we'll end with how to effectively use your medical staff development plan and provider strategy. Okay, so I've mentioned the words medical staff development plan and provider strategy already a lot this afternoon. What exactly are each of these items? What do they mean? What should they tell us? What are all those things? What is the difference between the two of these? Really simply, a medical staff development plan should tell you how many providers, including physicians and advanced practice providers or APPs, your organization needs within certain specialties within your primary and secondary service area. This is what we call a provider complement, or really the target amount of providers that you should have within each specialty at any given time. Additionally, this medical staff development plan should specify if those providers should be full-time, if this should be part-time, if they should be employed, or you should form partnerships with outside organizations to see if you can get some folks in a few days a month. It should specify all that information for you. Additionally, this medical staff development plan should not only tell you who you need to recruit, but who's key to retain with your organization. Where are there specialties where you really want to make sure that you've got your target amount of folks in that specialty at all times? And then additionally, where are there opportunities for further alignment or operational improvements within certain specialties? And finally, it should look at what's the public need in your community. Are you supplying the specialties that your community needs? Are there specialties that you need to grow? Are there specialties that you need to have that you don't currently? Or are there specialties that you have currently that you may not need to service your future population? How often should you conduct a medical staff development plan? A medical staff development plan typically predicts 5, sometimes 10 years down the road in terms of what you need for providers. However, it's best practice to update your medical staff development plan every 2 to 3 years. And this is really because the shifting nature of healthcare on a national level. I think the past 18 months have been evidence to that fact that there's a lot going on in the healthcare industry, and having a plan that's up to date with those events and variables that are somewhat outside of your control, making sure your plan is staying up to date with those things, making sure that you're engaging with your plan on a yearly basis to say, okay, are we recruiting the right amount of folks? Are we in accordance with our plan? Are we working on alignment issues where it's necessary? All those things are really important to make sure your plan is actionable moving forward. So what are the typical components of a medical staff development plan? Average medical staff development plans have two key analyses. The first is physician supply and demand based on population in your primary service area. So it's an understanding of, okay, if your service area has 25,000 individuals, you need X family practice docs, or you need X general surgeons. There's a couple studies that have this data in them, and it's what a lot of these results are based off of. Additionally, looking at access and wait times to specialties. And it's not only looking at, okay, how far out are providers scheduled, but it's also conducting what we call secret shopper calls. So it's an understanding of, okay, if I pick up the phone and pretend to be a patient and call clinics and hospitals within your service area, what's going to be the wait time that I'm told for a new patient? How does that wait time differ between specialties, in terms of primary care, OBGYN? How does that wait time differ if I'm a Medicare patient? How does that wait time differ if I'm a Medicaid patient? And you'd be surprised at the differences that we hear making those secret shopper calls versus what's actually on the schedule in terms of provider availability. So those are the two most common studies that we find that are included in a medical staff development plan. However, we think a lot of medical staff development plans miss some key components, and as a result, you don't get the holistic picture of what's going on at your organization and what your organization needs for the future. So that access to providers analysis, that stays the same. We're conducting those secret shopper calls. We're looking at the schedules of when folks are available. But that physician supply and demand based on population needs to be changed to provider supply and demand based on population. We're in rural healthcare. I think it would be a lot to assume that all your providers are going to be physicians. So APPs need to be included in here, and an understanding of the breakout of how many physicians do you need versus APPs, and what's that going to look like based on your current population and your future projected population. Additionally, we need to look at productivity and provider encounters for your folks, understanding, okay, we've looked at your population of 25,000 people, and in primary care, it says you need 8 primary care providers. But let's say you have 8 primary care providers and they're all working at absolute max capacity. Their productivity is in the 90th percentile. They're seeing 18 to 20 patients a day. That's a signal of, okay, we may need to go out and recruit an additional 1 to 2 primary care providers. And that's information that we may have missed. So it's really important to include those studies as well. Additionally, understanding the key kind of revenue analysis and what service lines and specialties are key drivers of revenue. So where do we want to limit gaps and limit turnover? So orthopedic surgery is a great example. We had an organization that had 4 to 5 orthopedic surgeons, but all of them were above the age of 60. So obviously recruiting in that specialty is going to be absolutely key, or else we're really losing access to that service line down the road. So again, these 5 analyses really form what we call that provider needs assessment. What's your need in your area? And that informs that provider complement, or that target amount of providers that you need per specialty, which becomes a really much more holistic medical staff development plan. So how does that medical staff development plan turn into a provider strategy? And that's where we really take it a step further. So this provider strategy really integrates your medical staff development plan to make it actionable at an organizational level. So we take that target provider complement and look at it on a 5-year timeline and say, okay, who's key to recruit in year 1 and year 2 versus year 3 and year 4 and year 5? Who do we need to recruit up front to make sure there's limited turnover? And what specialties may we need another 24 months to recruit for, keeping in mind that extended timeline that it takes to recruit specialists? So an understanding of, okay, who are we recruiting? When are we recruiting them? Who do we want to retain? And what operational alignment issues are we working on in years 1 and year 2 versus years 3 and year 4? We then take that 5-year timeline and let's overlay a compensation kind of cost overlay on top of that, an understanding of, okay, if we want to hire X amount of providers in these specialties, here's the estimated cost of those providers, and let's make sure we're including that in our budget moving forward. Let's make sure that we're working with that into our system strategic plan, that we understand we're going to have this increase in cost by bringing on these providers. How does this fit into our overall financial plan moving forward? And then one of the most key components is a detailed plan. And this is really the business case on a specialty by specialty basis that explains the rationale for your recommendations. So it's explaining the rationale of those 5 analyses that we've talked about and why the recommendation is the way it is. And this is something that's really crucial when you want to have transparent conversations with providers or with leadership or even board members about why you're taking these actions. You can lay out the plan and say, hey, we have a need of 8 primary care providers. We're already at 8, but they're all at the 90th percentile for productivity. They already have throughput that's through the roof. This is a really important revenue business line for us. We need to recruit 2 more folks. Here's our timeline of when we're going to do that, and here's the associated costs with that. Having that detailed plan in a format that's usable and able to be communicated is really, really important. So to recap, what are the differences between a medical staff development plan versus that provider strategy? That medical staff development plan is taking those 5 analyses. It's looking at your access to providers, those wait times. It's looking at your provider supply and need in the future based on your population at what it is currently, what it's going to be in the future. It's looking at productivity. It's looking at throughput. It's looking at high revenue service lines, understanding how that all incorporates into that overall provider complement. Provider strategy takes it a step further and says, okay, how can we make this actionable? Let's put out a 5-year timeline. Let's make sure this provider strategy goes and flows into that overall organizational strategy, that we've limited barriers to implementation. We're keeping these goals aligned and really is helping us develop further. Additionally, a provider strategy can go on a location by location basis. So if you're a rural health system that's got 3 hospitals, or if you're a hospital with a bunch of clinics, being able to understand, okay, what specialties do we need in what clinic and how many providers do we need in each clinic, that provider strategy will inform you of that as well. So with that, I'm going to head into our next polling question. Let that pop up for a moment. Awesome. Does a provider needs assessment, a medical staff development plan, or provider strategy make sense for your organization? So based on what we've talked about, do all of what we've discussed really make sense for your organization and is something that you want to work with moving forward? Great. Got about 40% of folks who have chimed in. Thank you so much. We'll give it about 10 to 15 more seconds or so. Okay. Right, we're at 50%. So 64% of you have said all of the above, which is great. 21% said provider strategy, also awesome. And then 14% said medical staff development planning. So why are these so important and how can these be really beneficial in kind of long-term recruitment? So a provider strategy really leads into long-term recruitment. And why is long-term recruitment so advantageous for rural organizations? Number 1, it helps prepare your workforce for the future. Planning 3 to 5 years in advance allows you to be nimble and take certain opportunities that you may not have when you're working on that 3 to 6 month turnaround time frame. A great example of this is Most rural hospitals that we work with don't have great referral data. It gives you an opportunity to start tracking things that may not be tracked in your EHR system. So engaging with providers to say, okay, what have you sent out in the past 3 months? And being able to look at what they've sent out on a longitudinal scale to identify, okay, are there some gaps in care? Oh, wow, we're sending out a ton of cardiology. Oh, wow, we're sending out a ton of pulmonology. Does it make sense to bring someone in for 1 to 2 days a month in each of those specialties to limit that out migration of patients? And this is opposed to just asking a provider once, what did you send out last week? You want to use that time to your advantage to gather data and plan your workforce for the future. Additionally, it allows you to be kind of creative with certain opportunities. A great example of this is if you have a need for both a general surgeon and a GI. We've seen folks hire retired military field surgeons who have hands-on experiences with a very large scope of general surgery and could do both general surgery and GI services. So instead of potentially waiting until year 4 to hire a GI physician, folks have instead found a civilian military surgeon where they got a head start on providing these lower acuity GI services and have gotten those things going at a lower cost. You're still providing access to that service, but you're not paying for 2 physicians, and you're allowing this ramp up time to then evaluate and say, okay, based on the procedures that this general surgeon is doing in GI, do we actually need to hire an additional GI surgeon in year 4? Does that make sense for our organization as the volumes have indicated? Another great thing about long-term recruitment is it allows you to tap into emerging talent. And what we mean by this is looking at groups of folks who are not only on the market right now, but potential providers who will be available in the market in the next few years. We've found that a lot of organizations, rural organizations specifically, have had a lot of success by looking for folks who have lived or trained in their community or have some connection to the surrounding area, such as their parents are from there or continue to live there, or their spouse's family lives there, or they've gone to the local high school. Those folks that have now moved on to medical school, and may not be looking for a job right now, but they will be looking for a job in 3 years. We've seen folks have a ton of success where organizations are keeping in contact and keeping relationships with those individuals and actually locking down contracts with folks years in advance. And it's a great way to kind of build up your bench of saying, okay, we have an individual who's going to come out of residency in 2 years, and we can overlap them with a provider that we know is looking to retire in 2 years. There's, of course, inherent risks with this example. They may not pass their boards, for example, but it's much easier to plan around that, and you're still in a much more secure position with that provider than thinking you can go out and hire someone in the next 3 to 6 months in this market. Frankly, post-pandemic, primary care is taking over 360 days to recruit an individual, and it's over 400 days for specialists. So when we're looking that far out, we definitely need to be thinking about longer term and who is up and coming, and are there populations of folks that we haven't looked at before. So how is long-term recruitment a win-win in terms of not only for providers, but for your organization? So for providers, if you're going out and having these conversations with folks in residency, you're able to then provide them with a clear career path and, frankly, long-term job security. These residents, unfortunately, for a lot of folks that are in residency, they're dealing with a lot of student loans and debt from medical school. So providing residents with a career path can alleviate some of that financial stress and allow them to really focus on their training and passing their boards and becoming a better provider. This relationship is only strengthened if the hospital can contribute to student loan repayments as well. And frankly, we've seen providers be very complimentary and positive about management of a hospital when this management is proactive and forward thinking. Providers enjoy being at an organization that is planning long term and understanding the needs of their community and is actively working to fill those needs in their community. On top of that, credentialing and onboarding, if you have this relationship with a provider, this long-term relationship with them, the credentialing and onboarding is going to go a lot faster. You can stick to that 90-day window to get it all done, which means your organization gets paid faster. And additionally, you can set up the provider you're recruiting with an onboarding buddy or a mentor within that provider that's a veteran provider that's looking to retire. They're inexperienced in rural or could be inexperienced in rural. So having that relationship with someone to ask questions, someone to help them learn the culture, someone to help train them on certain things and introduce them to their patient panel are all great ways that this new provider can become more comfortable in the rural environment. So what are the advantages of long-term recruitment for you as an organization? Smoother transition. Again, that passing off the patient panel from a veteran provider to that new provider and enabling that training session is really important. Some folks think that, it costs additional money to have that veteran provider overlap with that new provider, but really having a senior provider help train, pass off that patient panel and get a new provider up to speed, even if it seems like duplicative work, it makes patients that much more confident in the new provider. It helps reduce patient out-migration. Additionally, it helps reduce turnover in the support staff because that new provider is learning the culture of the organization. It creates confidence in the community and with the support staff and with leadership that, hey, we're maintaining access to care in this specialty and in the services we're providing. We're devoted to doing that, and it builds your rapport with community members and patients. So a fantastic example of this is our first case study. This was a Midwest Seoul community hospital. And this hospital decided to really work on its provider strategy after it had a change in senior leadership. And this is really common. Typically, when there's a change in senior leadership, it can trigger this type of conversation. So they were reworking on rebuilding their provider strategy. And one of their main focuses was a new primary care base. Historically, the hospital had relied on an independent primary care practice in the area, but these providers were beginning to age out and start to retire. So the hospital actually brought on a lot of these providers as that independent practice sold to the hospital. And unfortunately, a lot of those providers weren't engaging with the hospital. As of 2018, the hospital said, okay, we really need to re-engage these providers and work on some operational alignment issues. They started to do that and they realized, okay, we need to go out and start recruiting for new primary care providers. We've got a lot of folks that are aging out and we have a lot of volume that we need to address. And so what the CEO did was reached out and worked with residency programs and invited second and third year residents to visit the community and have them come and do regular visits and meet the providers and the members of the community to help them understand, okay, hey, is this where I want to live? Can I see myself here? Do I identify with the culture of this place? And by doing this, the CEO was able to contract with 4 primary care physicians who will join the organization upon completion of their residency. They know they're going to have 2 new providers in a 2-year period, and that those new providers are going to overlap with some of the former independent who are future retiring providers. They'll have that mentorship. They'll have that transfer of the patient panel. An additional 2 new providers will come on in year 3, and the same thing will happen there. So effectively, this CEO was able to address operational alignment issues. They addressed the ramp-up period, succession planning, transition of patients, and have done it in a really financially smart way that dealt with the retirement of folks from an independent practice. And it's a really fantastic example of how proactive thinking can have a huge impact on a community. All right. So what happens from an operational standpoint? When we talk about improved alignment and improved operational processes, how does that impact retention of providers and recruitment of providers? Number 1, recruiting providers is expensive. It's a really expensive thing to do. So if you look at operational improvements internally at your organizations, you may find that you don't need to recruit in the next 6 months. Maybe instead that becomes 2 to 3 years and gives you adequate bandwidth to recruit a specialist. You've addressed that gap in access to care risk. You're buying yourself some time. And maybe in that 2 to 3 year period, you still find that you need to recruit an individual. But again, you are still reducing patient wait times now. You're working on improving patient access now by doing those operational improvements. A big part of this is having conversations with providers and working with providers on what is realistic. What are the barriers that's preventing them from having patient throughput that they need to have? For example, if they're at a 14, how can they get to seeing 16 patients a day and still be realistic about wait times? Sitting down and having transparent conversations about this on a monthly basis is really important. Unfortunately, we see a lot of providers exit organizations because there were unrealistic expectations as it relates to call burden. They didn't realize what it's like to be on a 1 and 2 call schedule, is often the case with a rural call burden. So to have those conversations where you're saying, and being frank with providers is saying, okay, hey, I may not be able to get to a 1 in 3 call rotation, but what can I do to work with you to make this call burden more reasonable? Is it utilizing an APP as first call versus the physician? Would that reduce the call burden? Are there operational things that we can do to address this without, the provider leaving and you're finding this all out in the exit interview process? So again, engaging with providers on a regular basis about what is realistic and what you can do to meet their expectations with recruiting and what you may not be able to do is really, really important. Another big thing is that providers are expensive and we have to be able to compensate them fairly. And in many cases, there's going to be competition for compensation in your area. So how do you compete to be able to retain folks? Excuse me. It gives providers confidence in your organization when you're able to say, hey, here's our business case, back to that detailed plan aspect of provider strategy. Here's our recruitment plan. Here's the business case behind that recruitment plan and the clear, transparent data that supports that. Here's how we're setting realistic expectations of what we expect your volume to be, how long we expect your ramp up to be. Additionally, being able to present this to current providers and say, hey, we're looking to bring on a new provider in this specialty. Here's the business case as of why. Here's how your volume may or may not be impacted. Here's the data behind that. Again, having conversations around this and having transparency around the data is really, really key for these strategies to prove successful. All right, and with that, we'll head into our third polling question. Give it a second for it to pop up.
I actually don't have a third one in here.
Okay.
Do you have a slide? I can read it for you.
Nope.
If you want to read it. Okay. I apologize.
It's okay. My question was, is anyone using telehealth effectively within their provider strategy? And the reason behind that is, telehealth is a big part of our society now, and moving forward, Zoom webinars are a great example. So incorporating telehealth into your provider strategy can really have some strong benefits. For example, number one, it can expand your recruiting pool. It can attract providers that you may not have been able to entice before. So instead of folks that are on site all the time, 24/7, you can look at individuals who may be semi-retired or may need to be remote for some of the time. Again, these are clinicians that are working parents or people that are outside your region. It's a whole different pool of providers that you may not have been open to exploring before, now that telehealth capabilities are available. Telehealth allows you to kind of work on improving provider work-life balance. A great example of this is getting a specialist or a provider who may live in a different state. They may have kids in high school and middle school who can't be uprooted at this time, or their spouse may have a high-profile job and their spouse can't pick up and move. So instead, that provider can be remote for 2 weeks out of the month and on-site for 1 week and able to do that coverage for 1 week out of the month. So it becomes they have a better work-life balance. They get to see their family, but they're still providing services to your organization. We've seen this really be beneficial for night and weekend coverage for low acuity patients. It's something to consider, as it allows you to keep that 1 in 2 call rotation that's common in rural. So utilizing telehealth for that night and weekend coverage is something that we've seen a lot of organizations start to adopt. Telehealth can also help bridge some gaps in specialty. We see telehealth used a lot in psych. Behavioral health is also a huge space for telehealth usage. However, some medical specialties have also been really fond of using it. Nephrology and endocrinology are two examples. And what happens here is your primary care provider ends up doing most of the care management, but that patient can meet with the specialist at least once a month. So for example, in endocrinology, the patient can get their blood work done at the primary care provider and have that sent off to a lab. But a lot of what's going on, especially for diabetes management and care, can all be uploaded online. Folks can look at their blood glucose online, so their endocrinologist can say, okay, here's how we need to adjust your insulin levels accordingly. Again, all those things that can be done remotely where the patient's receiving care, but that provider is not on site. Telehealth is also a great way to work with a provider before they get to the community. So again, patients are familiar with their future patient panel, patients are familiar with their future provider. The provider is familiar with their future patient panel. And again, addresses that ramp up period, and they're able to feel more comfortable with each other. One of the big things with telehealth that you do have to pay attention to is how it's reimbursed. It can differ state to state, but it can really be a financially smart way to get ahead on provider strategy. So how do we effectively use a medical staff development plan or provider strategy? Now that we've talked about the importance of them, now that we've talked about what they each are, what are the next steps to implementation? How do you effectively use it and continue to use it on an annual basis? So for a medical staff development plan, you want to outline and do all the things that would have been done in a provider strategy. So number one, you need to clearly define, okay, what are the specialties where we need recruitment or alignment work or retention work in years 1 and year 2 versus year 3 and year 4? Where are there critical roles that are at risk of retirement? Where are certain providers that are saying, hey, I'm done in 6 months or I'm done in a year and a half? Where are those roles? Where do we have to quickly work to fill those roles? Then we have to tie this to the finances. We have to tie it to budget. We have to understand how compensation of recruiting new providers, how that's going to play into things if you bring them onto the system. Making sure that's incorporated into your organization is critical. Figuring out where care is most vulnerable. Again, where you may only have one provider in a specialty. So making sure you're actively recruiting. If that provider is getting to retirement age and they leave, that specialty is gone and access to that specialty is gone. So making sure that you have identified those specialties of saying, hey, this is one that we really have to monitor and watch out for, and we need to build up the bench for a couple years down the road if this provider decides to retire. And then finally, if you're an organization that is a health system with multiple hospitals in rural, or if you're a rural hospital with multiple clinics, understanding how specialties and providers are spread out amongst those clinics or amongst those hospitals. Where is it really important to have certain services based on your population, based on volumes that are in those areas? Again, understanding how providers can split their time and where you need to recruit new providers to is super important. So with the first steps of implementing a provider strategy, you will already have done all those things that were outlined in a medical staff development plan. So with a provider strategy, it's all systems go, it's launch time, let's start moving and grooving. It's about launching those recruitment efforts and retention and alignment efforts. So it's about going out and speaking with those folks that are still in residency. It's about going out and forming those connections with individuals that may still be in school or have ties to your community. It's about working in transparency and having communications with your current providers about, hey, here are areas that we really need to work on alignment. So again, planning for those long lead specialties that you need to recruit in years 3 and year 4. It's a heavy, heavy lift if this is your first medical staff development plan. Within years 1 and 2 of your medical staff development plan, not only do you have to recruit for providers that are critical needs during that time, but you're also going to have to start thinking about who you need in year 3 and 4 based on lead times and wait times. So if it's your first medical staff development plan, it's a heavy lift at first, but once you get the ball rolling, it becomes easier to manage because, again, you're starting to be able to think proactively and be more nimble and flexible. addressing, again, those alignment challenges, making sure you're working on barriers towards implementation of those alignment issues, having clear communication with providers, and engaging with future talent and folks who are not currently in the workforce but will be soon, again, are key components to making this provider strategy be integrated into your system. So one of the big questions that we get a lot is, okay, that's great and all, but how do I start to have these conversations with providers, especially around operational improvements or alignment issues? I don't want to stir the pot. I don't want to create animosity with these providers where there is none. How do I have, productive, healthy conversations with these folks, or start to have these conversations with these folks? The number one thing we'd say is that by being transparent with data and sharing it openly, you're gonna start to build that trust. So that business plan, that detailed plan that's in your provider strategy that we talked about, having that clear rationale of why some of these decisions have occurred and how you've approached them is really important. And then asking for their feedback and opinion on some of those decisions, including them on the provider strategy process, inviting them to the table to participate, inviting them to the table when it comes to recruitment and saying, hey, we're going to go out and look at, these folks, how do you feel about how they fit with our culture? Please, let's have lunch with them. Let's do this work with them. Again, giving them a seat at the table to drive decision-making and have some ownership in this process as well, typically yields better results because they feel some responsibility for the provider strategy itself and moving it forward. Additionally, demonstrating, hey, here's what's going to happen if we don't do this. Here are the financial consequences that will come as a result. Here's what we could face if we're not actively working to address these issues. That's a big thing that frankly, in a lot of clients, providers sometimes don't understand. So working with them around that, and again, presenting data in a transparent way is really important. So we'd be remiss if we didn't discuss on a lot of rural hospitals that have or already are in existing partnerships, how to start having conversations with an existing partner about medical staff development plans or provider strategy. We've worked with clients that are part of larger health systems, and being able to, again, to have a constructive conversation around medical staff development plans and provider strategies is something that a lot of our rural clients are looking for. So number one is to begin with quick wins and build trust. So that's start focusing on those easy arguments, those business cases that make absolute sense. So it's those cases around primary care, for example, where, hey, we are already meeting what we need to in terms of current and future supply and demand for primary care providers, but our productivity is through the roof. The encounters for these providers is through the roof. It's a huge revenue generator for us. This is a no-brainer that we need to go out and recruit more primary care providers. Tying that decision to financial impact and to the bottom line of the organization drives a lot of these points home with existing partners. So within primary care, it's understanding, okay, by bringing on more primary care, we're going to enhance referrals, not only to ourselves as a rural hospital, but to the system partner as well for higher acuity cases potentially. By having these plans in place, we're reducing the time and costly recruitment delays that can come. We're reducing the gaps in access to care that could occur. Again, tying all this to the financial bottom line and showing that existing partner, hey, we've thought about this to be from a financially smart and strategic position. And again, acknowledging with the existing partner, you've been creative with a lot of your thoughts and ideas, understanding where it makes sense to, hey, instead of hiring a full-time physician, maybe we only need a full-time APP to cover the additional volume that's going on here. Do we really need a full-time physician to do this work, or is this something that an APP can cover for less cost? Again, making a financially smart decision, but still getting you what you need in terms of providers and allowing your patients to have increased access to care. So again, ways to kind of start that financial conversation with existing partners is easy business cases that are going to build trust, tying it to the bottom line and showing them that you've had creative thinking and thought about these solutions in depth. So a great example of this is with a Mid-Atlantic rural health system that we worked with. We worked with this health system. They own multiple critical access hospitals and a large tertiary referral center. And we worked with them regularly to develop a MSDP every 3 years for over a decade. They used their MSDP in a variety of really creative ways, and it helped them really do the following. Number one was support getting J1 waivers approved. An example of this would be, this organization will go out and say, okay, we need an ENT. And they'd search for an ENT for a year. And if they didn't find anyone, they would expand the search to J1 applications. The MSDP that they'd done demonstrated the community need, but behind having an ENT, demonstrated that business case. So that business case could be included as part of that J1 application that then would get approved. Additionally, they use the medical staff development plan to support providers who had high productivity. So basically documenting fair market value for Stark and anti-kickback compliance, and being able to say, hey, this is the demonstrated need in our community for this specialty. This provider has extremely high productivity, justifying this comp and making this comp necessary to retain this provider and make sure that we have access to this specialty in our community. And finally, they use the medical staff development plan to look at, they had a bunch of outreach clinics in their service area, and they use the medical staff development plan to understand, okay, what specialties do we need in these clinics to service the population, and how many providers within each specialty do we need to have in these locations. So again, from a geographic standpoint, they were able to take that medical staff development plan and use it to say, based on the community need, based on what the data analysis we've done, we now know we need X amount of providers in each of these locations in these specialties to service what folks are primarily going here for. So we've talked about folks that are in existing partnerships. We hope a lot of rural hospitals can continue to remain independent. Unfortunately, the reality is that a lot of folks are looking at potential partners. So if you're looking at that somewhere down the road and you're saying to yourself, well, do I do a medical staff development plan or provider strategy? And then if I have to affiliate with a partner down the road, or I'm looking at a partnership, how is this going to be perceived? Is this something that's advantageous? We'd say yes. Any existing strategy or plan that a critical access hospital or rural organization has and is actively implementing only increases or only puts you in a better position, in a position of strength and negotiations with a potential partner. It shows that potential partner a few things. One, that they don't have to do that research for you. They don't have to do that data analysis for you. You've done it for them. You've gone out into your community and understand your provider supply and demand. You understand what you're going to need in the next few years. You've already worked on that long-term planning. You've already formed those connections and built up that provider bench by looking at folks you can recruit in the next 2 to 5 years. You've done that. You've identified those resources. And those larger partners, those regional referral centers, they're facing the same physician shortage. So anytime that you've built up a bench of providers is a really key thing to have done if you're going into a potential partnership discussion. It's a really key area of leverage, frankly, to have. Again, they don't need to necessarily invest additional resources to assess your market or define specialty support and need, because you've already done all those things. So it plans, one, that you're making financially smart decisions, you're ready and are educated in what your community needs, and it really just builds partner confidence in the organization's direction, and again, gives you more of a position of leverage when you're going into those discussions. What are some key takeaways from this discussion today? If you've learned nothing else from this chat today, I hope you've identified a couple of these things. Having a medical staff development plan or provider strategy in place and updating it every 2 to 3 years can really only be beneficial to your organization. It helps you plan in terms of understanding where your gaps in care are going to be, what specialties are really important for your community to maintain, what specialties you may not have and need, what specialties you have and may not need. It helps you plan for long-term recruitment. Again, looking out at that year 3, year 4, reducing that time of a gap in access to care, anything you can do to reduce that gap can only be beneficial to your organization. Engaging with providers on improved operational processes, things that you can do now while you're recruiting or before recruiting to build up, again, access to care for your patients in the community, but also inviting those providers to have a seat at the table and have those conversations around provider strategy and what you can do to increase productivity and increase throughput at your organization. And finally, making sure that medical staff development plan or provider strategy supports the overall organizational strategy. Again, make sure it ties to that financial aspect, make sure it ties to the budget moving forward, make sure it ties to your system strategy, because if it doesn't, it's going to be so much harder to maintain that provider strategy and keep it being actionable and keep working on implementing it. So again, making sure those documents are tied together is really, really important. And with that, that's the end of our chat today. I'm really happy you all are here. I'm happy to answer any questions. And if we can't answer them today, this is my email. Please feel free to reach out. Always happy to answer questions or have discussions. Yeah, we'd love your feedback on if this was helpful to you or not. So don't forget to fill out that survey at the end. And with that, I'll turn it back over to Cody.
Thank you, Claire. We're going to go ahead and open it up. It was a great information. I know there's going to be some questions. I have one already. I'll get to that in a second, but don't hesitate to ask your questions. Put them in that control panel. We've got a little bit of time, and I know Claire is here to help. So, Claire, the first question that came in: what are the current studies used to determine provider need based on population? Provider need based on population.
Yep, it's Hickson, Glenn, Group Health, and Geminac are 3 studies that are still used to this day. They're dated, but they are the most up-to-date studies that are out there currently.
Wonderful, thank you. Go ahead and put your questions in that control panel. We'll be sure to get to them. Another question that came in, Claire: how do we make sure our MSDP is aligned with long-term goals and not just immediate vacancies?
Great question. Again, it's about, hey, that year 1 and year 2 is going to be a heavy lift. It's about tying it to the financial bottom line of your organization and your overall system strategy and making sure you're planning ahead. So it's not only who are you recruiting in year 1 and year 2 that are critical needs that you need to fill fast, but it's also working in year 1 and year 2 on recruits needed in year 3 and year 4. So to get the ball rolling, it's a heavy lift, but once it is rolling and you're proactive in your approach, it becomes so much easier to work in advance to fill those gaps in care and do it in a manner where you're not losing patients or losing volume as a result of folks that are retiring or not having adequate succession plans.
Thank you so much. Another question: what role should current providers have in developing or updating a MSDP?
Yeah, absolutely. Providers should definitely have a role understanding who are kind of the key leaders in your providers, inviting them to the table, having them be a part of the conversations and the decisions, and sometimes even the forming of the provider strategy is really important. So again, making sure you're sharing data transparently with them is super critical, and having regular check-ins. So this isn't just a yearly check-in. This is something that you're doing maybe every 3 months, every 6 months, maybe even more often than that if you get it moving correctly. Again, it's about having and establishing a relationship with these providers on these matters so they feel like they are also drivers of this plan and can help implement it down the line.
Okay, thank you so much, Claire. I don't have any other questions at this time, but we do have a couple minutes, so if there's something on your mind, go ahead and put it in that panel. Claire, I'll hand it over to you right now for any closing remarks.
I think I'm just so happy you all are able to attend today. Again, please feel free to reach out to my email. I'm happy to answer any questions that you may have as it comes to medical staff development plans or provider strategy, and hope you all have a great rest of your Wednesday.
Thank you, Jody, for the thumbs up. I love to see interaction. This is a new platform. It's still GoTo, but it's a new updated platform, and it allows for some fun things. So thank you for showing us your support. Thank you for joining us today. We hope this session provided you with new insights and ideas to take back to your organization. As a reminder, this recording will be sent to your email inbox later today. You can revisit anything you found especially helpful and take down Claire's information. I know she's always willing to answer any questions, and I know you guys always have them. So please don't hesitate. You can always reach out to me as well. Yes, there is a survey at the end. I know we don't like doing it, but please, if you could take just a minute, I'd really appreciate it. It gives me a lot to keep these sessions relevant for you. Also, if you're looking for additional resources or anything that you need, leadership skills, expand your team's impact, please visit nrhasc.com. It is a site that we built just for you. It is all rural healthcare access, resources, everything that you need, or feel free to reach out to me anytime. I'm always happy to help. And finally, a special thank you to Stroudwater Associates for your ongoing support as a Platinum Partner. We couldn't do these sessions or conferences or anything without you, and we appreciate all the work that you do. All right, with that, I'll go ahead and close this out. Everybody have a wonderful, warm Wednesday. Spring is on its way, and we look forward to seeing you all at our next session. Have a great day, all.
Thanks, all.